Okay, we are complete, and we're going to get started now. So good afternoon again, everyone. I'm Kevin Fenton, the current director, and I need to say that in the presence of this very august group of panelists, the current director of the National Center for HIV/AIDS, Viral Hepatitis, STD, and TB Prevention. And it really is my great pleasure to welcome you here this afternoon to reflect on 30 years of CDC leadership on HIV/AIDS. You know, one of the core themes of this conference this year is not only reflecting on the national HIV/AIDS strategy, but as I said in my opening talk yesterday, to really think about this conference as a pivotal time to think about where we've come from over the past 30 years and where we're going, where we're heading, certainly for the next 30 years with the response to HIV, both here in the United States and globally. As you heard from many of our speakers yesterday, CDC has really been at the forefront of both the identification and the classification and the response to the prevention response to HIV/AIDS here in the United States. And clearly we have, as an organization, contributed to the global response to HIV/AIDS as well. But part of this has been because of you. Your leadership in the community, your leadership as advocates, your leadership as prevention partners, which have been a very consistent part of the journey that we have had to travel at CDC as well. So many of the accomplishments that we've been discussing over the past 2 days reflect the joint partnership between ourselves as an agency and leaders within this agency and you as a community of people interested in, affected by, or living with HIV/AIDS. So the purpose of today's panel is to take a step back, to begin to think about who are some of the key leaders who have been some of the key leaders over this 30-year period in the fight against HIV/AIDS in the United States. To introduce these leaders at a time when we are reflecting on the past 30 years, to hear from them firsthand about some of their own experiences regarding leadership on HIV/AIDS, to unpack what lessons can be learned from the first 30 years from a leadership perspective that can help us to enhance, strengthen, or deepen our prevention response as we move forward. The leaders that we have gathered here today bring a diversity of perspectives at diverse periods over the 30 years in the response to HIV/AIDS. And I can't think of any better group of leaders to really help us to reflect on key lessons, but also key opportunities moving forward. So the structure of the time that we have together will be as follows. I'm not going to do any formal reading of biographies or introducing colleagues. They will be introducing themselves. We will begin by asking each panel member to both introduce themselves, provide a brief summary of their key leadership role at CDC in the past or present, what they're actually doing now, and to ask them to reflect on one momentous occasion, looking back on their tenureship at CDC, what really has one of the key momentous occasions for them that they would like to begin the discussions on this afternoon. When we've heard from all the panel members, and you've heard the diversity of both experiences as well as the key memories from the 30 years, I have a list of prepared questions. But I know that this group is very, very vocal, and I know that you will also have your own questions as well. So I'm going to be inviting questions from the audience to be posed to the panel. And we will share the questions to the panel, both from the audience and from myself, in a very interactive fashion moving forward. So, without any further ado, I'm going to ask our panelists to introduce themselves. I'm going to be moving from the person closest to the podium, who is Dr. Harold Jaffe. Harold. You can sit.
Well, thank you, Kevin. I started working on AIDS in 1981 with Jim Curran, and if any of you were at the last session on The Band Played On, you know what we did for the first couple of years, and then continued on in a number of roles in the program, which expanded very considerably in a relatively short period of time. I left CDC in 2004, having been the director of the National Center for HIV, STD, and TB Prevention, and spent 6 years at the University of Oxford, and came back about a year ago to be Associate Director for Science at CDC. So I don't have a direct role in AIDS right now, but obviously try to follow it and stay involved as much as I can. We can talk about anything we want.
Anything you want.
Oh, my God. Well, I won't talk about anything from the first 2 years because that was the subject of the last hour and a half. I think the most sort of difficult, interesting thing that I was ever involved in was the Florida dental investigation. I did a sabbatical in a laboratory in London from 1989 to 1990, and I came back July 1st, 1990, and on my desk was a draft MMWR that described a young woman in Florida who had developed AIDS, and her only known risk factor was having received care from a dentist who'd subsequently died. And Jim Curran was going on vacation, but there was a note on it that said, "What do you think about this?" And I'm unable to repeat what I said because it would be bleeped. But I thought, oh no, this is terrible. The first challenge that we faced was, should we say something about it, or do we need to do more investigating? And we went sort of back and forth and finally decided, well, we need to do both. We need to be investigating, but we can't just sit on it. So we put out the first report and immediately got criticized for jumping the gun. I don't know if that's Jim's memory of it or not. But, this was premature. How do you know you're right? You're suggesting a new transmission route from healthcare worker to patient. And tremendous denial. Carol Cizelski, my colleague, and several other people from CDC, including a contingent from our laboratory, continued on with this work with a lot of help from the Florida State Health Department. We ultimately identified a total of 6 patients who we believed had been infected by this dentist. A lot of the evidence was from the laboratory. That is, they had a strain of the virus that was virtually identical to the dentist's virus and different from a number of other people living in the same community that we considered control patients. So we thought, we don't know how it happened, but it did happen, and what are we going to do about it? I think very naively, I thought, well, I'm a doctor, and these people are professionals. They're dentists and doctors and surgeons and OBGYNs, and they'll understand that the primary issue here is protecting patients. And I was wrong, because the primary issue for them became, you're saying to us we can't practice if we're infected. That means we don't have a livelihood, or you're telling us, I trained to be a surgeon, now you better be a radiologist or a pathologist. So instead of getting cooperation from the medical establishment, we got a huge amount of flack. And it was extremely contentious up until the very end. I think a lot of it was based on, because we never figured out how it happened, that it couldn't have happened. And our view was we couldn't figure out how it happened, but it did happen, which I still believe. Ultimately, we were able to develop a set of guidelines, which I'm not sure satisfied anybody, but basically said that it was a professional responsibility for surgeons and dentists to know if they were HIV infected. If they were, and they performed a certain subset of procedures, ones that would be the most likely to expose the patient to their blood, then they should not be doing those procedures unless they've been approved by essentially a group of peers operating at the level of their hospital or their health department. Many people were unhappy with that. They felt that it was a compromise that didn't suit their needs. But it's still the recommendation. It actually hasn't changed since 1995 or so when we issued it. So again, it was fascinating in a certain way, and it demonstrated the power of our laboratory to be able to link together infections in a way that we could never do before. But it was a very sort of sobering and a disturbing example of how people's self-interest sometimes becomes their main interest.
Great. Harold, thank you. And just so the audience is aware about where you were in the organization, you were my immediate predecessor as a director of the National Center, but you held other leadership roles as well.
Yeah, this is when I was, I guess I was director of the AIDS division then. AIDS division. Okay, great. Jim.
Well, I worked with, as you saw in the last session, I worked with Harold for the first 15 years until 1995. And I guess when I left CDC, I was associate director of CDC for HIV before they had a reorganization. And I think I followed Gary Noble in that job, maybe. And then since then, I've been Dean of the Rollins School of Public Health at Emory and Director of Emory Center for AIDS Research. So I remain engaged in AIDS. And I've been thinking that, you know, Harold and I were involved in a lot of issues, and a lot of times the issues don't seem quite as intense or passionate in retrospect, maybe even to us, but I mean, the amount of anger in orthopedic surgeons and dentists and a lot of people about this case was incredible. And the Congress, Tom Coburn, cut his teeth on this, and he got interested in this in Congress and showed that he could beat Tom Coburn. But hi, Tom. I guess what I think of, though, is there are a lot of things that people may criticize us for, and you may hear about, you may do that when you get to the Q&A, but I think the biggest things that I'm concerned about from a CDC point of view that maybe we could have had more impact on. One was early in the epidemic, and one was mid-range, I think, which continues. The early one was we didn't take enough ownership and deal with the epidemic and injecting drug users. I think, you know, the federal government is a territorial place, and that was SAMHSA's job and NIDA's job. And even though we communicated with them, that was their job. And injecting drug use was at the very roots of the heterosexual and black and Puerto Rican epidemics in the United States. And I somehow think that CDC somehow could have been more influential. Now, this was a Reagan administration. There were a lot of other stuff going on. But the drug abuse epidemic was horribly neglected and mishandled for the first 15 years in the United States. And I just somehow think that if we could have done a better job with that, we could have been more effective in the heterosexual epidemic and in the epidemic in women and children. And that we should have been screaming from the rooftops and ignoring our jurisdictional barriers. The other thing that I neglect, and I continue to neglect on behalf of Jono and Kevin today, is just as I was leaving, and all of the time we were doing testing, we've always known that people with HIV infection are uninsured. And they've been uninsured from day one, and treatment is very expensive and needed. And the Ryan White Care Act in 1990, I guess, acknowledged that. But I wish that when I was at CDC, I'd taken more of the bull by the horns, particularly when Clinton was president and everybody was rich and they were talking about health care reform, to really link testing and prevention and care more closely together. I mean, it remains a horrible sin that someone can't be tested for HIV, particularly if they're at risk, and can't be guaranteed access to life-saving care, which we've kind of always known had a very big prevention benefit. Back from the Florence AIDS Conference, when the partners of people with AZT had less likely transmission of AIDS than the people who weren't on AZT. And so my regret is that we didn't deal with CMS and HRSA much more directly and arrange for uniform Medicaid waivers in every state in the union, and didn't take much more of a link between prevention and care at a time when the country had some money.
All right, thank you, Jim. Kevin, Dr. Kevin DeCock.
Thank you, Kevin, and do stop me if I go on for too long. When that MMWR in 1981 came out, I was working in Africa, and most of my involvement at CDC has been international. And I remember pretty much where I was sitting in the library of the University of Nairobi in late 81, early 82, when I read an article in The Lancet about what was subsequently called AIDS. I first came to work in this country in 1983 in Los Angeles to actually work in liver disease and with a special interest in viral hepatitis. But by then I was already more interested in AIDS, and of course the patient populations of hepatitis patients in LA had a strong overlap with HIV. And in fact, in there was an epidemic going on in LA that we were heavily involved with of hepatitis delta virus. HDV superimposes itself on hepatitis B. And we had a huge serum bank, and were able to do a number of seroepidemiologic studies, which were extremely illuminating once the HIV test became available. I didn't really know what CDC was in those days. Well, I did, but I never thought I'd go there until I met Jim Maynard, who was the head of the hepatitis branch. And I remember him meeting with him in late 83, and talking about AIDS and asking what he thought this was. And he said, I think this is a disease from Africa. That really stuck in my mind, because I subsequently wrote a paper on that which made that argument, and it wasn't completely right, but it was partially right. Mm-hmm. When I came to CDC in '86, I started working. I thought I was coming to do hepatitis work, but they didn't have a job for me, and ended up working in hemorrhagic fevers, the group that did a lot of work in Africa, and also the group that, under Jim's collaboration and leadership, had sort of made the forays into AIDS in Africa. Jim and Joe McCormick, my supervisor, had arranged for the setting up of a very successful research site in Kinshasa, in the Democratic Republic of Congo, headed by the late Jonathan Mann. And I was just fascinated by all of that. And as an EIS officer, worked on HIV in Africa and also in West Africa, and persuaded Jim to support the establishment of a second research site to look at the second HIV virus, HIV-2, which we really didn't know much about, which we didn't test for, which theoretically could have been a public health problem for this country, including for the blood supply. So Jim and Harold really were my mentors at that time, and it's just been an extraordinary privilege to work over time with them. There's an anecdote I always remember. Our research site in Abidjan, the work went well. I was succeeded by Alan Greenberg, another well-known epidemiologist from CDC. But I always remember the first site visit we ever had, when we had a delegation from CDC that was bigger than the number of people working in our project. And Harold, I remember Harold sitting there in his characteristic way, sort of shaking his head, saying, if we can't diagnose and distinguish HIV-1 from HIV-2, which was a real laboratory challenge at that time, we might as well all go home. It's a great encouragement. And Jim at that site visits, sort of sternly saying, well, when are you going to start your first cohort study? I remember that very well. Anyway, just to fast forward, I actually started doing some domestic work from 97 to end of 99 with David on my right, when I was the director of the Division of HIV/AIDS Prevention, Surveillance and Epidemiology. And I guess there are 5 things that stick in my mind, that big issues we could come back to. The very difficult discussions about HIV surveillance, and going from AIDS case reporting to named HIV reporting. A wonderful experience and great community dialogue, but difficult politically as well. The contention around the research trials on the placebo-controlled trials on mother-child transmission prevention that were going on in Africa and Asia. The death of Jonathan Mann in a plane crash in 1998. The whole debate about HIV testing, particularly in clinical settings, which is an issue I've been quite involved with over the years. And then the whole issue of viral load testing, which was being much more used now, and the effect of ART on that, and the discussions which actually we had a decade ago about the use of therapy as a potential prevention modality. And then after that I went back to international work, and I'll stop there for the minute.
Great. Thank you, Kevin. Dr. David Holtgrave.
Thank you very much, Dr. Fenton. This reminds me, being on this panel, of the Saturday Night Live skit of Wayne's World. You've seen Wayne and Garth say, I'm not worthy, I'm not worthy. That's exactly how I feel. But nevertheless, it's a great honor to be on this panel. And just in terms of working at CDC, I started in 1991, where it was a great privilege to be hired by Dr. Ron Baldessari, who's here, to work on program evaluation and cost-effectiveness issues for the National Program on HIV. And after a couple of years in Ron's office and getting a chance to work with Ron and Gary West and others, got to go over to Jim Curran's office. And one of the first things we did was there weren't any review papers or systematic reviews at that point of what do we know about prevention interventions and what do we know about the evidence. And so that was one of the things we tried to pull together for the first time. And then from 95 to 97, I should say, too, at that time, working in Jim's office, this was the time when HIV prevention community planning started in the U.S. And I remember the meeting, actually, in Jim's office where that gave rise to the start of community planning. And that was a major point for us. And earlier, Jim mentioned at the previous session about the role of behavioral science. And I actually think the role of behavioral science in community planning was really an important time as well, too. And then from 95 to 97, I went to Jeff Kelly's center in the Medical College of Wisconsin and came back pretty quickly in 1997 when Helene Gale asked me to direct the other half of the Division of HIV/AIDS Prevention, Intervention, Research, and Support. So it was great to work closely with Kevin over those years. And it was there until 2001, and then went to work at Emory with Jim in the Center for AIDS Research at the Public Health School. And in 2005, went to Johns Hopkins to chair a new department called Health, Behavior, and Society. And the part, though, that I wanted to go back to just sort of highlight was during the time of 97 to 2001, was when the Minority AIDS Initiative first started. And I wanted to sort of call that out because I think it's such an important example of how different partners play different roles in the epidemic. In March of 1998, we knew what some of the, at that point it was more AIDS case information, but what the health disparities looked like in terms of race, ethnicity, and especially with regard to African American and Latino communities. But the African American disparity was just incredible. So we asked 33 leaders from African American communities and faith communities to come to Atlanta and hear the presentation that we had to offer. We knew what we could do, which was to provide technical information, talk about the programs that we were offering, but we also were not allowed to go directly to Congress, and it was an example of what I call the dance of people inside of government and outside of government sort of working very closely together, hand in hand. And Dr. Benny Prim was one of the 33 people who were there. Immediately went the next morning, actually, to see Representative Stokes, and the Appropriations Committee was meeting, and that began the discussions around the beginning of the Minority AIDS Initiative. And a lot of partners were involved. There was the Congressional Black Caucus, the staff members from Congressional Black Caucus. It was a time during President Clinton's administration, and Sandy Thurman is here, who was head of President Clinton's Office of National AIDS Policy. Their office, ONAP, was heavily involved. And also the Department of Health and Human Services, and a wide variety of partners, including of the 33 people who came at that March meeting. There was a group called the Palm Sunday Group, and some of you may remember the Palm Sunday Group, also known as the Insurgents, was the label that they used as well. And we're making sure that we talked constantly. We talked almost weekly about what progress we were making and whether any money could become available. And first, there was a call to make this a public health emergency. And it turned out that technical, everybody used public health emergency, except officially in the federal government, a public health emergency meant like an Ebola outbreak or something like that. So we couldn't use that term. So the term that was used was a severe and persistent crisis of ongoing public health attention, which, of course, if you look it up in the dictionary, means public health emergency, of course. But that was the term that had to officially be used. And that next fiscal year, about $166 million was made available. There was about $50 million that was in the Secretary's Emergency Fund. And I wanted to mention the Secretary's Emergency Fund because we could see at that point the beginning of a tremendous epidemic among black gay men in the U.S. And so we were allowed to write proposals for money out of that emergency fund. And so we asked, and I think got about $9 or $10 million for the first dedicated CBO program for black gay men in the U.S., which I thought was incredibly important. Also, the state health departments played an important role. One of the things that we focused on at that time, and if health department representatives or NASDATs here, you'll remember are discussions about the budget tables. How was money spent by race, ethnicity, and by risk? And within 2 fiscal years, you could actually see a lot of money move to really very much mirror the epidemic burden in the U.S. and actually could see some progress being made. Of course, there's never enough progress, but you could see definitely a movement. And I think that was to the health department's hard work of trying to see that that money was moved. And then also at that time, we tried to make sure that the directly funded CBO program was moved around so it much more reflected the disparities that we were seeing as well. And, I think that the only other recollection I want to make from that time, and Sandy will remember this, in her office, Office of National AIDS Policy, there were panels from the Memorial Quilt. And one of the panels, which I never forget, had someone's ashes in it. And what was written, stitched there was, leave me here until there's a cure. And often I think about that panel in knowing that there's someone in limbo, someone there whose ashes are still in the quilt, whether that's now in the warehouse somewhere here in Atlanta, and not until there's a cure can we release the ashes from that person who was on the quilt in your office, Sandy. So I will end there. Thanks.
Great. Thanks, David. So, Jono.
Great. Well, thank you. First, I think not only am I the most recent person in this position, but I think I've also been in for the shortest period of time, so I will be proportionately brief. The first is a question of kind of looking back at, what have you done that you think might be a moment worth discussing? And I think it's impossible to know that at the time, because there's almost weekly events of conflict and opportunity when you're in this position. But I think one of the major efforts that probably we'll learn soon whether it's a good or bad effort is the integration of prevention and care. The whole idea of seeing them as mutually supportive. And that has been a major issue for the division while I've been there, and we'll see in the next few years whether that's been productive. But I did want to ask you, a lot of the leaders here at the table have raised the question of, looking back, what are the things you might have done differently? And I think that honest reflection is a wonderful thing to do, and I try to do it as frequently as possible to both chastise myself and learn from the experience. But sometimes our passion in the past has overcome careful thought, and sometimes political perspectives have overcome best judgment. And and that's actually been problematic. That unwillingness to listen and work together, I think, has sometimes really harmed people with HIV and even our efforts. And I looked back it must have been the late 1990s. I remember reading in the New England Journal of Medicine an article written by the then director of the Division of HIV/AIDS Prevention, I think, or maybe he was a staff member at that time, but he's no longer in the division. But he had written this argument saying that that hospitals that have inpatients with 1% or more diagnosis of AIDS should all have routine HIV testing. And I remember writing a pretty scathing letter saying how this isn't accurate, it's not going to work, and really deeply concerned about the human rights of people with HIV. And then I found myself 5 years later moving for a 10-year stint in Uganda and Kenya running CDC programs on HIV, where I was spending a lot of my time working with local government and hospitals implementing routine HIV testing, and I can actually count the literally tens of thousands of people who were alive because that was happening. And so I've looked back, and I with discomfort in my kind of knee-jerk reaction, my sense that I was unwilling to really look at how things were changing, and also understand that I came from a good place. I really did, but I do think that I was wrong.
Okay. Dr. Noble, Gary Noble.
I started at CDC as an EIS officer in '65 and did a study among Eskimo children out on the western tundra of Alaska. I was given an opportunity to spend a year at Oxford University in '80, '81, and I remember where I was sitting when I read the first MMWR reports. I met Walt Dowdle, one of the great leaders of CDC, at the International Congress of Virology in Brussels in September, and he said, "I think this is going to be a big problem," and that turned out to be a prophetic understatement. Returning to CDC that fall, I encountered the amazing team that Jim and Harold led, working almost nonstop around the clock. I was put in charge of the virology laboratory and flew off to New York and San Francisco with my laboratory colleagues to collect blood samples in the attempt to try to identify an infectious agent. Obviously, NIH and Pasteur Institute beat us to that, but that's not important. Walt decided in the fall, late 83, that there should be an international conference on AIDS, and asked if I would chair it. I said no. The next morning I called him back and said yes, I would. But Bob Kromisher and I can share the challenges of chairing the program committee for a major international conference. It was a far cry from today's AIDS conferences, but it set in motion those international AIDS conferences. Secretary Heckler was the one of the opening speakers, and at the press conference after her speech, she was asked when there would be a vaccine, and with Bob Gallo standing at her side, she said, in 2 years. We do hope that Holy Grail soon appears. I was then asked to serve in Washington in the Assistant Secretary of her Health's office, since he was a cardiologist and wasn't terribly up on infectious diseases. That was an interesting year. It was the Reagan administration, and Gary Bauer, whose name has been mentioned in the prior conference session, was the AIDS spokesman. Sharing a platform with Gary Bauer was not a comfortable experience. Being on Larry King Live with a young gay activist was also a little uncomfortable, although I totally sympathize with his views, but representing the Reagan administration, I didn't necessarily voice all of my views immediately. In terms of regrets, I suppose that might be one that could have been a little more outspoken. At a meeting of the White House Domestic Policy Council chaired by Mr. Reagan, Secretary Otis Bowen asked me to attend, since on the agenda were going to be 2 items of discussion that he knew would be of interest. One was, should people with HIV be allowed to enter the U.S., to attend conferences, etc.? There wasn't a discussion. The Chief of Staff dismissed it, simply saying, of course, that won't be allowed. The next question was, should there be a report to the nation? I knew of Mr. Reagan's admiration for Maggie Thatcher, and I had just obtained a copy of the report that Mrs. Thatcher had sent out to the British population. That's why when Mr. Reagan asked if there were any questions, I raised my hand and pushed across the table that report. And of course, as you know, and I'm not suggesting that stimulated this, but because I think Reagan had already asked Dr. Koop to write a report. Dr. Koop, bless his heart, was a good friend 3 doors down the hall, and he wrote that report with interviews of nearly 30 different groups representing a wide spectrum of views. He wrote it himself, largely standing at his desk at home with one NIH staff person. When he had it printed, he took it to the White House Domestic Policy Council Cabinet meeting, handed out numbered copies, and said, I want it back at the end of the meeting, and I want to know your thoughts, and they all approved it. So he then called a press conference to release it. Went off to Russia with Weingarten, the head of NIH, came back to find that the press conference had been canceled, walked down into Secretary Bowen's office and rescheduled it. It was a very interesting, tell it like it is, frank report, and Dr. Koop has always earned my respect for that. I think that I will not add any more. Time is pressing on, but I think CDC has had a major leadership role in the nation and the world to be proud of, and putting good science with dedication, compassion is important, and I'm sure that will continue. There are lots of opportunities for continuing challenges. One of, I think, is going to be continuing challenges, treatment as prevention. And you heard Paul Kawata, perhaps yesterday, talking about the ethical issues that arise from prevention as a tool to prevent transmission and those tools are becoming readily more available, but who is going to make sure that they're used and that they're paid for? So I retired from CDC in '94 and went on to Johnson & Johnson to help launch an anonymous, confidential, supported service with counseling that was approved by FDA, but was taken off the market because it didn't make enough money.
Great. Thank you, Gary. So we've heard brief reflections from each of our panelists, and I'd like to invite those of you who'd like to ask questions directly to the panel to please make your way to the front of the mic. I'm just going to kickstart with a question which is about the role of advocacy, and I think an activism in the HIV response. And many of us who were not here in those first few years of the HIV/AIDS epidemic perhaps will never understand the depth of passion, the depth of anger, the sort of animosity between the community and government, or what we sometimes read about, hear about, see in films on the early AIDS response. Could you share with me and the colleagues here how this activism and advocacy has changed your practice as a public health leader or practitioner? Please.
I think it was great, and is great, and it's somewhat missing now from AIDS. I think one of the things that characterized AIDS compared to many other public health problems was the strength and power of advocacy, particularly among people who themselves were HIV infected and dying. And I think they brought an enormous amount of power to a movement that could have gone the other way. I mean, I wondered in the early 80s whether the AIDS epidemic would drive gay men back into the closet. And I think instead you saw thousands and thousands of people marching and acting up. Now, sometimes the weapons were fired rather broadly, and there wasn't sufficient target practice ahead of time. That's particularly true when people like me were the target. But I think none of us at CDC were ever personally harmed physically, and I never really took it personally. I always thought that this was advocacy that called for stopping the band from playing on, and that it was very important, and it was one of the reasons that we in government, who were ourselves constrained from necessarily doing what we want to do. I mean, let's face it, you can't always tell the whole truth. And if you're in government, you represent the administration. And Kevin and Jono work for President Obama directly, indirectly or something. And so they can't say certain things. One example is that most of us couldn't really tell everybody what we really thought about needle and syringe exchange. So it takes people in the community to make a difference. And I think that AIDS activists did that. And I think we've seen almost relatively little activism in the last 15 years, which has kind of died with the press attention and mortality rates, and that's one of the reasons there's less attention to AIDS.
I think it's worth making a comment on the international aspects of it, because I think internationally advocacy increased as well in places where it really had never existed before, particularly sub-Saharan Africa. And the advocacy around the 2000 International AIDS Conference held in Durban in South Africa was immensely influential, and I think directly contributed to the massive increase in funding for international HIV programs, including through PEPFAR. So I think it was immensely important. I think there are some advocates who, quite remarkably, have become very deep experts. I can think of several individuals who become medical experts in their own subjects, treatment, tuberculosis, and so on. And finally, there is something strange about AIDS. I mean, we understand why it's garnered this movement of advocacy and outrage and bizarre, unusual coalitions that never existed. And we understand some of it, and yet there's sort of an element that is almost ununderstandable and almost mystical, if you will, because there's plenty of diseases that are terrible and, injustices and so on, and yet none of them have managed to build this coalition to quite the same degree that HIV/AIDS has, and it merits reflection.
I think a couple of things. One is when I was at CDC, there was this sort of instruction list of what you should do if there was protests on site. And one of the things that sticks in my memory was that we were instructed that we should, this was in the days of handset telephones, we were to take the cord out and take the handset with us, I guess for fear that there would be unauthorized long-distance telephone calls made during a protest. But thank goodness we never had to employ that strategy at any point that I knew of. But I think if there's one thing that I miss right now, it's the level of activism and the level of advocacy that we had heard before. Certainly it's alive and well. But I think that level of passion really does make a difference. And as I said before, I think knowing kind of where the dance works. I think many people who work in AIDS, whether it's in health departments, government, academia, CBOs, whatever, share a mission that looks an awful lot like the vision statement in the National AIDS Strategy. But it's sort of knowing what are the pluses and minuses of each of our jobs, and how can we meld those together in some way to make a big difference. And also, the last thing I would say is, I think the activism, for me, one personal thing I took away was really learning much more about active listening. And an important form of activism was from the Native American communities that we interacted with, who would come and be very concerned about HIV in Native American communities, largely concerned about surveillance and measurement issues. But people would take turns speaking one at a time, talking about what the epidemic meant in that community. And that form of active listening, I think, was incredibly important and something we don't maybe do enough of these days.
Great, thanks. Well, we have a couple of questions at the podium, and I really do want to give time and encourage colleagues to ask questions. So, please.
It might take me a few seconds. I've waited 28 years to ask this question. I am 28 years old. Any 80s babies in the room? So I like to say that when you all were fighting AIDS, I was fighting my diaper. And then 8 years later, I would come to be diagnosed as a transfusion-acquired AIDS patient. And so I'm very proud to be standing here today because I'm currently in month 9 of my time at CDC. So aside from all the AIDS history and things like that, I personally, 28 years seems like a really long time for me, only because I'm 28. So I was just wondering, CDC person to CDC people, if you had any words of advice for me as a new person to public health and both to CDC, but really old to AIDS.
Well, that's a wonderful question. I think one thing to know, as an institution, CDC is an extraordinary place to work because it has the resources and the kind of the influence of a governmental institution, but it tries to do its best. It's several hundred miles from D.C., and that benefits our ability to kind of think independently at times. And so I think there are many people who work at CDC and really do care about the institution. It's not perfect, but it does pretty well. And I think the other thing is, think whenever you're trying to make decisions, take the moment to look back and see. Just kind of, do I have the right evidence, enough information, and I'm making the decision with enough reflection. To make the right one. And I think at CDC that's supported. So, I remember when I was on the wards as a physician at San Francisco General Hospital, and I remember, it's frequent that, it's 2 a.m. in the morning, you have a patient who has a problem, and you call the surgeon to come to do, this really needs to go to the OR. And the surgeon is, says, no, they don't. I'm really not sure whether the surgery, they start going down this long list. Really what they're saying is the person has HIV, and I don't really think they're going to make it, and I don't want to take the time to do the surgery. And you're saying, well, your view is, well, I really think this person is. But you end up talking, instead of the subtext, you end up talking about, explicitly you're talking about, does the patient need the service, and is it the best thing for that individual? And almost always the right decision is made because you have a common place for discussion. And I think at CDC, we have the same thing. Certainly within HIV, we have a common language of doing the best for the people who we're responsible for, and hopefully in the end you make the right decision.
Jim, I think you want to respond. You got a couple of responses.
Well, Nina, we've met before, and I know you're well trained. As an alum of the Rollins School of Public Health, applications are sitting by the door.
Now, if I had to choose about what I would do differently, I do have one. I would have gone to public school. Now that I'm in loan repayment, it's a good problem to have.
Anyway, I guess, I'd like to echo what Jono said about the importance of training and data. And the two things about working at CDC that have made it rewarding for a lot of us, I think. One is, the science-based approach and the fact that there is a bureaucracy that will actually deliver and is committed to deliver. And so you have to know what you know and what you don't know, and you have to know the limits of government and limits of bureaucracy. But the other thing about CDC that made it maybe most rewarding for me is the passion of the people who work there. And that's more important than obeying the rules and the bureaucracy. Some of the best things that have been done at CDC have been done despite the rules. And the people who are most effective are not always the smartest or the best trained. They can quit and get fired, but on the other hand, the people with the passion to get something done and a commitment and passion to what you do is something you should never lose.
Great. Thank you.
Thank you.
Next question.
Hi, good afternoon. My name's Glenn Acken. Apart from my photographic talents, I'm reaching my 40th year at public health service at CDC and HRSA. And I just attended the syringe exchange presentation, and it brought up a question that's always been in the back of my mind. Obviously, I lived and worked through it, and I recognize the politics that Clinton and Shalala had to go through. And I was just wondering if there was some thoughts that you all had in terms of the impact of not approving syringe exchange back then, and where we would have been, or, would there have been an impact at all? I think not. I think yes, but I'd like to hear what your thoughts are.
I'd love to answer this question. I think that I really care a lot about substance abuse and treatment of it and prevention of it. And I think that the syringe exchange argument got caught in the midst of the scarcity and our general disdain for drug users. Virtually everybody hates heroin addicts and cocaine addicts, and so therefore they're the bottom of every community, and they get the lowest priority in the block grant. They just don't get anywhere. And I think when you start with that attitude, and then you say, well, let's just do syringe exchange, you leave yourself vulnerable to a problem. So the best example I can give of this, when Steve Joseph was health commissioner of New York City, there was a widespread methadone maintenance program. Somebody mentioned Benny Prim earlier. Lots of people have been involved. But it was a scarcity program where there were a lot more heroin addicts in New York City than there were methadone maintenance sites. So Steve Joseph wanted to do a syringe exchange program. In order to get it done, he had to take people on the waiting list for methadone maintenance to do syringe exchange. How stupid can you get? These are people that want to get off of heroin, and you throw them a needle. What is the problem? The problem is heroin addiction, and the problem needs to be addressed on the part of using syringes to get people into treatment, not onto a waiting list. So the overall problem of injecting drug use and our horrible mismanagement and disdain for drug users and the lack of any kind of program that treated it at any level, and I think the lack of voice at CDC when I was there about how important it is, was at the roots of the epidemic in minority community, in straight minority communities in the U.S. And it got caught up on the syringe exchange battleground because there was such a gap in scarcity for everything else. But undoubtedly, syringe exchange would help. But I would hope that whoever gives out the syringes would say, brother, you ought to go into treatment, and be able to say, I can show you a treatment slot.
I think one of the things it shows is, well, two things it shows. One is the sort of inability of political systems sometimes to think very rationally, and secondly, the huge diversity internationally around this issue and the need in public health for pragmatism. The term harm reduction, which, if you use the WHO definition of that, actually includes 6, 7, or 8 individual interventions, of which needle and syringe exchanges are only 1 or 2. That term was, politically unusable, which is kind of regrettable, actually, because if you think about what internal medicine is, management of diabetes or coronary artery disease, what you will, most of that actually is about harm reduction, reducing the progression and the harm of whatever condition it is, obesity, we wish our individual patients didn't have. And I mean, the whole issue of harm reduction for injecting drug use, I think, is very much like that. In health, in medicine, but in public health as well, we have to deal with the world that we face rather than the world we wish we were living in. But in terms of pragmatism, it's extraordinary how different countries have different policies, or how they apply different policies. And unpredictably, sometimes, a country like Switzerland, which is a fairly conservative society, is extraordinarily pragmatic in its application of interventions like making needle and syringes available for drug injectors, but actually doing much more than that, even having safe injecting drug rooms where people can inject under supervision. So, we know they're not overdosing. The fact that a conservative place like that can do these innovative things, it's just not a feature of this particular country.
Great. Next question.
Thank you, gentlemen, for your comments. One milestone that stands out for me in AIDS history is Ryan White being not allowed to attend school. I know that for a fact that COOP was more than actively involved in the process of getting Ryan back into the schools. Can you tell me what CDC's roles and activities were at that time?
I don't know the circumstance specifically of Ryan White's being allowed to go back to school, but this was a time when there was tremendous fear about unknown routes of HIV transmission. And it was a time where people were literally afraid to sit next to somebody with HIV, to be a member of a community with an HIV-infected person. And there was a particular focus on fear in schools. I suppose because parents felt that, here's a risk that my child doesn't need to take. And the argument of, well, gosh, not having a seatbelt on your child going to school is probably putting your child at a lot more risk than having another child with HIV was irrelevant. It wasn't part of the discussion. That was the bad news. The good news was, though, that despite all these fears about transmission through mosquitoes and sitting next to people on the bus and all that, eventually the American public got it. And I'm sure there are still examples of irrational behavior towards HIV-infected people. But the great majority of that eventually went away as people started listening, as their worst fears were not realized, and it just vanished. I don't know if other people see it that way, but I do.
Gary?
Just a comment about the difficulty of putting into practice what you know intellectually. The year that I was working in Washington for the Assistant Secretary, our daughter called and said that her classmate, freshman classmate at Auburn University, had just come and told her that he had an HIV positive test, and could he come home and talk to me, since he knew what I was doing. And of course we said yes. So he came and spent the weekend. And when he left, Peggy and I looked at each other and said, we haven't done anything differently. We aren't treating the dishes or the linens in any way differently than we would have. But you did think about it. And that was 86 or 87. So getting people to accept, but I think as Harold said, in today's world, I'm not aware that there's much of that kind of lingering reservation.
No, As we wait for the next question, one of the hallmarks of the epidemic in the U.S. today is severe, pervasive health inequities, a severe disproportionate burden of the disease among African Americans. And some would argue that the way the epidemic has evolved in the U.S. is consistent with other patterns of STIs within the U.S., whether looking at syphilis and how that's evolved, gonorrhea, how that's evolved. So the question to the panel is, given what we know today about how the epidemic has evolved and the health inequities that we're dealing with now, are there things that we could have done differently in the earlier years of this epidemic to circumvent these health inequities? Or do you think this was an inevitable path that we would be experiencing? That's a slightly challenging one there, but one that I think a number of colleagues are grappling with today. What could we have done earlier so that we don't have black women in the United States being 9 times more likely to be diagnosed with HIV than white women? So,
I would turn the question around and ask you a question, Kevin, which is, I don't know why HIV infection rates are so much higher in African American gay men than in white gay men.
Mm-hmm.
I still don't understand it.
Mm-hmm.
Listening to people who work on this, like Patrick Sullivan, sexual behavior really isn't different. So without knowing why it is, what are we going to do about it?
Okay. I tell you what, I'd love to hear the panel. Nice try, but nice try. But I'd love to hear the panel on my question, and then I'd be happy to.
Well, we appreciate your polite deference, you big chicken. But I've already said one thing, and that is the roots of the heterosexual epidemic in black and Puerto Rican Americans was injecting drug use.
Mm-hmm.
That's different from STDs. The problem with HIV is once the prevalence gets high, the incidence is going to be high.
That's right.
And if you infect 200,000 injecting drug users, 95% of whom are black and Puerto Rican, and they're infected for life, you've guaranteed that you're going to get, and they're all heterosexual for the most part, you're guaranteeing that you're going to have an East Coast epidemic of a sexually transmitted infection independent of the behavior of the people, the sexual behavior of the people. So I feel quite strongly that the roots of some of the disparities in heterosexuals are related to injecting drug use and our society's inability to deal with that. The second part of it is we need national health insurance really badly. And every time we want to do something, we run into the same old problem, and it's always been true, that people with HIV and AIDS don't have health insurance. And it's just over and over and over and over. And you guys battle that, and you just can't get around it. You test somebody, nobody will pay for the damn test. You want to get them treated, they stand in a waiting line. And those people happen to be black and Hispanic more often than they're white, with HIV. And so, you know, those are two things that are really hard to get around the corner of. And a lot of talk doesn't do it.
What you're really talking about are the social determinants of health, and they apply to HIV, but they apply broadly to all kinds of other health issues as well. I think I agree with Jim that the injecting drug use issue has had a huge impact, as he says, but I don't think it's a complete explanation by any means. Well, once an infection is established, of course, then sexual networks take over. People have sex with people like themselves. In fact, it's even more stereotypic than that. People have sex with people whose parents resemble their own parents. It's actually, I mean, there's data to show that. What we see in the United States with African Americans actually is replicated in other countries with native populations, in Canada, for example, in Australia, New Zealand, and in France. But in France, because you're not allowed, because if you're French, you are a French citizen, and it doesn't matter, you're not allowed to ask questions about race, ethnicity. You're French. Therefore, these kinds of differences are hidden because nobody measures them, and yet they're predictably there. Mm-hmm. So it's actually a much more broad question than just affecting the United States.
Mm-hmm. Okay.
So I think one of the things we might have tried to do more of earlier, but I still don't know exactly how to do this, is in cases, well, the issue is sort of how can the health departments and CDC have partnerships when the state legislature or the governor really is a barrier to programs being implemented well, especially programs for gay men. And earlier I talked about the budget tables with health departments, and we looked by race, ethnicity, but also looked at how the money was being spent matched to the disproportionate burden among gay men, injection drug users, and other populations at risk. And I think it was sometimes hard to figure out how do you bring national level pressure to bear when it's a state government issue. And I think that that's something that needs continued attention over time, and it's something I wish we could have figured out earlier.
Okay. There's another question at the podium. And we will come back to Dr. Jaffe's point on black gay men in the U.S.
Great. I'm Carolyn Wester from Nashville, and I just want to thank everybody for their past and also current leadership and service. Thank you very much. And I wanted to, along the lines of advocating for clients to get treatment in an uninterrupted way, ask for the panel's thoughts and ideas on the large percentage of the HIV population that's going in and out of corrections, and recognizing that we've got different funding streams, even for those that we can get on Ryan White, whether they may be going into jails or then state or federal prisons, and recognizing the ill effects of rebound viremia or interruption in care on not only individual but population outcomes in terms of transmission and health. And if we can advocate perhaps, or I don't know if the new Affordable Health Care Act will follow them in and out of corrections, but what we can do in the context of very expensive treatment regimens to not just leave them to the county's jurisdiction and pay the price public health-wise.
So, thoughts on the correctional system, its impact on the HIV epidemic, and solutions?
Well, thank you for your initial comment, and a question I think is also a comment. This is a major issue. I mean, I think it reflects some of what has already come up, that the system doesn't cover everybody, and people who are in corrections or have been in corrections are some of the most discriminated against people in society. And so, and they also, it's very hard for that link when you leave either jail or prison to find yourself in either the old place, in a new environment, or in a totally new environment where you don't know really how to link into services. So we do recognize that as an issue. Certainly in the current work that we're doing in our division, it does have some of the issues that raised before of not our jurisdiction, not our area, but yet an area we care about. So we have to do a better job of leveraging other kind of resources and people throughout the nation. Pilot programs that show that it works have already been conducted, so we know it works. It's just, what do we need to do to actually initiate that policy change that will allow that to happen in a more comprehensive fashion? So I think we're in full agreement that this is both an important area and an area we're not doing enough in.
Maybe cost-effective studies on more expensive regimens and things like that. Are those have already been done, or no?
I'm sorry, cost-effective studies of
I'm just thinking cost-effective studies of keeping somebody on treatment and not changing their regimen, averting new cases, and avoiding more expensive regimens.
There's even prevention arguments. There's cost. There's so many arguments that this works. It's really just getting it done. I think that's the step. I don't think there's a convincing process like we might have had with syringe services as much. Everyone I've talked to at the highest levels of government agree that this is an area, and the national strategy highlights it. But it's actually getting it done when jails are funded, as you know, through the counties, and they're having budget reductions. And most people who go through jails last for hours, if only, and the vast majority, fewer than 3 days. So if that's happening, how do you introduce something where you might actually diagnose someone with HIV and then be responsible for them versus actually not doing that? It's a very hard change, although some jails have done it. Prisons is actually a different situation, as you know. They actually are better funded, but they still have some of the same issues.
Just quickly to add to that as well, and this sort of goes back to Jim's earlier point about access to care. I was by 2003 or so, it was on an IOM panel that looked at public financing of HIV care in the U.S., and we were supposed to look at expanding public access to HIV care by looking at block grants, expanding Ryan White, looking at Medicare and Medicaid, And we did all of that. We sort of fulfilled our charge and did like 2 years worth of cost effectiveness analyses, trying to look at all these different strategies. And at the end of the day, the only thing that we could come up with that we thought was a data-driven recommendation was exactly what Jim said, which was it should be an entitlement program, and everyone living with HIV should have transportable care across jurisdictions, across venue types, inside of prison, outside of prison. And when we released that report, we thought, yes, we knew that was a bold statement, and we knew it was maybe a little bit impractical, but still we thought that's where the data led us, and we should say it. And at that time, HHS issued a press release when our report came out, and it was a one-sentence press release and said, the panel has overreached its charge, period. And
Okay. Next question.
Hi.
Sorry.
I would do a series of case control studies of deaths. I mean, I think the only thing people care about is deaths. And I think nobody cares about prisoners, and then not enough people care about poor people or minorities or HIV. But maybe if we found out that the deaths that occur in the United States are due to the inadequacies of our health system, we might be able to get somebody's attention. And I just don't see, in the absence of national health insurance, all of this running around trying to figure out who should pay what and everybody's trying to avoid paying for it is profoundly depressing. Medicaid doesn't want to pay for it because they're cutting their budgets. The prisons are cutting their budgets. Ryan White doesn't have enough money. The federal government can't do it. The states can't do it. I mean, you're just bouncing around the place when a rational thing is, what if somebody had breast cancer or something, Would you be arguing about whether or not they should have a mastectomy if they went out of prison? I mean, it's stupid. The whole thing is just so stupid. This is a fatal disease. It makes me mad.
Hi, I'm Terry Wilder, and I don't really have a question other than I just wanted to share something. I was sad that I missed the last session because I'm a professor at a graduate school of social work in New York City, and I teach HIV and social work. And I just wanted the panel to know that one of the things that's really important to me is that the students that I teach understand the history of HIV. Many of them only kind of understand from today, the future. I think it's critical to understand what happened in the early years of the 80s, that it was not easy and it was a very uncertain time, and that the very first week of class we do watch And the Band Played On, and we do have a discussion about it, because I think it's just critical to kind of, if we don't understand where we came from, we don't really understand what we're doing here. So I'm thrilled that in 2 weeks I get to tell them I got to see Dr. Jaffe and Dr. Curran in real live, and it wasn't just those characters in the film. So I just want to say that, although you guys seem to be those characters.
I think we have an objection here.
Wait.
Just remember that Jim Curran says that the actor that played him should have been better looking.
Oh, okay. But I do have a question related to And the Band Played On. I'm just curious as to what Don Francis is doing.
I think that following retirement from this, he left Atlanta while the movie was being made, and was assigned to the California Health Department for the last 4 years of his public health service career. Then when he retired from the public health service, he went to work with VaxGen, which was a spin-off of Genentech, which was developing a vaccine. And he drove the testing of the vaccine through vaccine trials in Thailand and the United States in a very professional trials that were conducted. Unfortunately, the vaccine was not effective. But he did that for a number of years. VaxGen then expanded its own scope beyond HIV, and ultimately Don took a subunit, I think spun off another company, and then I believe he retired. I saw him about 2 years ago in San Francisco, and he kind of talked about being semi-retired.
I have two answers, one serious, one not. The not serious one is he's the lead actor in the movie Contagion. Actually, I saw a letter from him, I think in the New York Times the other day, and he is in San Francisco with a group called something like, and I think he's the president of it, of something like solutions, global solutions for infectious diseases or something like that. But he's in San Francisco.
Great. I think there was another person at the podium. Yeah, please.
Hi there. Thank you so much for the perspective. As someone who hasn't been in the workforce itself very long or in HIV very long, what's I think exciting to me about this time is that the strategy has given us such a clear vision. Before becoming a program manager, I worked in public education for 3 years, and I think, you know, public health, public education, both very broken, but perhaps at least this issue of HIV/AIDS being united by a very clear and distinct vision. And your perspective has seen various administrations. You've been through, as an institution, liberal and conservative administrations, and I'm wondering, from that long-standing point of view, what you would say to CBOs and to just citizens, to advocates, to friends, to individual Americans. There was a question raised yesterday about November 2012 and its potential implications. And that aside, you've been through, again, various administrations. You will continue to be there as an institution. What can we be doing, again, as CBOs, as individuals, to be strategic regardless of the administration that's in power?
Best answered by some of the current federal employees on the panel.
I'm happy to do that, and this will be a very non-federal answer. I think. So I think, kind of harkening back in some ways to the plenary session this morning, is thinking about the goals of the strategy are so important and so clear. And I think then the issue in many ways is, are we going to have the resources to be able to do that? And I think that that's something that, in thinking about the dance again inside of government and outside, it's not something that our federal partners can talk about very easily. They can educate but can't lobby. But it's something that people outside of government can do. And you know, I think one price tag is that probably prevention is about $350, $400 million a year short in the U.S. And I think we have to keep pressuring for that. Now, that could be new money, it could be redirected, it could be private sector, but we have to keep pushing for that, because I think without that, it's going to be very, very difficult to meet all of the goals of the strategy. And I think it's one of the issues where, you know, I find it difficult that we even have to have this conversation where now with the FOA, the only way we can find new money which is needed in some areas is to take it away from other areas. And I think if we were in an era where we actually had prevention fully funded with the other $350, $400 million, we wouldn't be talking about shutting off the AIDS hotline in Massachusetts for the first time in a quarter century and ending programs there. We'd be talking about how to make sure those programs are as accountable and efficient as possible, and then making sure that we're pushing forward with the new money in the way that's really necessary. So there should be accountability everywhere across the board, but it troubles me greatly when I think about the national strategy and how much we're underfunding it. Also, as we talk about fiscal accountability, I truly believe in all our analyses that if you want to make sure that you're going to drive up medical care costs for HIV, the best way to do that is to underfund prevention. And that's exactly what we're doing now. We're underfunding prevention, and we're going to pay many, many more times for that in medical care costs down the road.
Just a comment on the politics. You know, the president and the Congress serve in the context of the environment. So you have, and you know, the AIDS epidemic changes, the economy changes. Sometimes you have a Republican president and Democratic Congress, and vice versa. And so the reality of politics depends upon a variety of things. Right, and in general, I think if you're working on AIDS in general, the Democratic president can set a tone which feels better than often the Republican president has. That doesn't necessarily mean there's more money. I mean, clearly the big increase in global AIDS money came under George Bush. I mean, that also got us, you know, a lot of abstinence programs and a lot of other kinds of things that were politically familiar. So you have to kind of judge if you're a citizen. You have to judge, you know, how do you feel about the leadership? I mean, President Obama has a big national AIDS strategy, but hasn't been able to put a lot of money into it, and hasn't really, you know, been able to step back and say, what are we going to do to assure everybody with HIV has appropriate medical care? because the priority was national health, and was Obamacare, what the Republicans call Obamacare, the Affordable Care Act. And now the priority is trying to dig out of the ditch of that we're in the country and get reelected. And so the context is really tough for politicians now, and the states are going broke. So it's a very, very difficult time to act and expect any kind of real action. But it might not be a bad time to plan and to put some real meat behind the strategy and to say, what would it really take to do this strategy? What kind of health system would we have to have if the Republicans don't totally, emasculate the Obama Affordable Care Act? What would it take to really get this done? And then how would we have to refine our testing recommendations in order to make them compatible with the health financing recommendations that we come up with? And to come up with some really serious plans so that when the economy gets better and the political forces get better aligned, they could be implemented. Because I'm fairly pessimistic about anybody expecting any big increase in much of anything in the next couple of years.
So the final question, we're almost to the end of the session. I'd like to begin by answering Dr. Jaffe's question and posing yet another one to the panel. And Dr. Jaffe asked, why are we seeing these tremendous increases, of near 50% increase in HIV incidence in black gay men over the 4-year period, 2006 to 2009? And Harold, that's been a focus of this conference. And in fact, we held a media briefing on this today. But in short, I think there are multiple determinants operating at multiple layers, and there's no one answer. You're correct that black gay men have lower levels of risk behaviors compared to their white and Hispanic counterparts. That's in a context of high background prevalence of HIV. So therefore, with any risk behavior whatsoever, the probability of acquisition of HIV is higher. We are also seeing concomitant increases in syphilis within the same demographic, which can facilitate HIV acquisition. And as we discussed this morning in this morning's sessions, black gay men are the nexus of both race and sexual orientation in the United States, dealing with issues related to racism and the structural and social issues that arise from that, but also the stigma and discrimination related to being black and gay within communities across the U.S. And in the session this morning, we spoke about many of those social and structural determinants that Kevin mentioned as well. So the final question then to the panel, Harold, and thank you for stimulating this discussion, is, given what we now know about these multiple determinants affecting the lives of black gay men in the U.S., are there things from your retrospective experience that we, John and I, and our current leaders today in this room should be thinking about doing better or faster or more thoughtfully moving forward in responding to this?
I would offer probably a politically not very correct response, which is what we're learning, which is probably what we've known for a long time, is the best way to prevent HIV infection is to treat people who are infected. Mm-hmm. It seems to me that if we're going to make a real impact on this sub-epidemic that we're talking about, it means that we really have to focus our testing and treatment efforts on that population. Mm-hmm. Now, I'm sure that's easier said than done, but if you want to make it an impact, I think that's the way you do it.
Carl? Jim?
I guess I would add, I've always thought what you articulated more clearly, and that is when you have something that's a source of stigma and discrimination, that's not good. But when you have two things, that's worse. And so if you have racism and homophobia, you have homophobia within your race community as well as without your race community. We had a panel discussion the other day that Jono was there, and we had, really strong members of the African American community and strong members of the gay community really getting on each other a little bit about who should get more attention. I mean, that's the way I would look at it. And so there's competition even for the epidemic response and the money. And I think that, what Harold said is absolutely right. But one thing we have to do is honestly look at ourselves and say, how do you build consensus about doing something about this within society? and the societies that exist, and pay real attention to discrimination and homophobia, both within and outside the black community. Because I think if you don't do that, you're neglecting it. I mean, it's simply not right and can't be tolerated to be either racist or homophobic in the United States. And it has to be discriminated against at very high levels and very low levels within communities. And it's you know, that's sort of theoretical. But I think that there's an awful lot of stigma and discrimination that's in the middle of this, too.
Kevin?
Yeah, my comments, I think, perhaps touch on some of the other questions that came up, like, you know, what would you do as a young professional today and so on. And I think the first guiding principle, especially for CDC, has to be, you know, we should be driven by data and evidence. And that has to be the fundamental of everything we do. But at the same time, you know, being right is not enough. Sometimes we see very senior people who believe that, well, I'm right, and of course, you know, but the world doesn't work like that. So it's extremely important also to have the necessary coalitions and political constituencies, and that's clearly true in this particular regard. The problem has to matter to the community that's affected, and I think, and again, to speak frankly, I don't think HIV matters enough to the whole African American community, and that's something we have to collectively work on. The HIV clearly mattered to the gay community in the early 1980s in a way it doesn't anymore, and the way it hasn't to any other affected community. And yet there was real power there that we haven't seen for a while. I think we have to also use, as Harold said, we have to use the emerging scientific data. We have to be driven by science in our interventions, and, you know, as everybody knows, what the developments in the last 12, 24 months have been really quite extraordinary, and we've got to use that. We have to use that. And we have to change our funding decisions from things, this is domestic as well as international, from things that we know don't really work, or we don't have a lot of evidence they work, to things that do work, or where there's evidence. And yet we also have to use judgment. You can't get away from the need for judgment. So be careful not to throw out the baby with the bathwater. But two final comments. The discussions about healthcare in this country are discouraging. I mean, the United States seems to be proud of the fact, or there are elements in this country proud of the fact, that we don't have treatment and healthcare available for everybody. And it's an extraordinary, internationally this is viewed as very perplexing. There are other aspects of society that one could talk about also, but nonetheless it's an issue. And finally, for this meeting, 30 years into the epidemic, men who have sex with men remain so disproportionately affected. That's a global phenomenon. It's not just it took us a long time to figure that out. I don't know why. But we have to ask ourselves, is it really acceptable that, going forward, is HIV just going to be an inevitability in the lives of gay men for the foreseeable future? It's a remarkable, black or white, or of other ethnicity. It's a remarkable question and troubling issue.
Okay. We'll just continue with closing comments related to this question.
Thanks, Kevin. Just very quickly, I think we also have to look at what are the disparities in health service delivery as well, too. And thinking about Baltimore, it's such a severe epidemic among black gay men in Baltimore. And if you look at lack of awareness of seropositivity, if you're a black gay man living in Baltimore and living with HIV, chances are about 74% that you won't know that you're living with HIV. It's an incredibly high level of unawareness of seropositivity. And when we look at some of the determinants for that, some studies that we've been doing, one big driver of lack of awareness of seropositivity is no access to health care in the last year. And so I think there's access to HIV treatment, but even simply access to the healthcare system overall, too. And I think that's something we need to do.
I would simply echo Kevin's comments that you really have to set priorities, and the incredible challenge is increasing awareness of the problem. But when you deal with the realities that treatment isn't going to be available, trying to initiate leadership in the black community and in those at the highest risk in the absence of access to care and treatment is a mind-numbing reality. But that's where we are.
Great. Jono, any closing comments for Janet?
Thank you, everyone.
So this brings us to the end of the session. I want to acknowledge some leaders that are in the room that weren't on the podium. We had Dr. Ron Valdezeri, who was in the room. I'm not sure if Ron, are you still here? And Alan Greenberg is here, who also played a key leadership role at CDC. And there are also other federal leaders, such as Dr. Carl Diefenbach, who are current, or my peer, currently in the fight against AIDS today, working at the NIH. I want to thank you all for joining us today. And Sandy Thurman, Sandy, thanks. Also another great leader over the 30 years, the first 30 years of the epidemic. Thank you for your leadership. Thank you all for being here this afternoon. And a thank you to our panelists.